Welcome to Not Too Tight, Not Too Loose, the podcast about finding balance in the pursuit of well-being. Welcome again, Andrew.
Hey Joe, how's it going?
It's going well. How about you?
Good, good. I'm excited to set up this next episode
Yeah,
with our friend
yeah.
Kyle.
This was a fun one. Our friend Kyle Greenway, he's a psychiatrist at McGill,
Hmm.
working clinically at the Jewish General Hospital here in Montreal and doing lots of cool research. Such an impressive dude. I just love talking to him. And what I sort of suspected going in and was like super validated was that he's a not too tight, not too loose kind of guy,
Uh-huh.
right? As evidenced by the work he's doing, at McGill and everything that he's done. So, yeah, first, first reflections on that interview.
Well, I guess we'll let our listeners gauge for themselves where he fits on the not too tight, not too loose spectrum. I mean, maybe where to start. The interesting thing for me. So Kyle's doing research with ketamine and also doing ketamine assisted therapy in a public setting. But we talked to him a lot about psychedelic-assisted therapy and how it's evolved over the years. So we met Kyle, a while ago now in Montreal, and he was just sort of getting going in this frame. And he does have very nuanced, thoughtful ways of approaching psychedelic-assisted therapy. Right, not a panacea, not a magic bullet. Right,
But also
and
not business as usual.
and also not business as usual, right? And business as usual can be very different in a public institution, right, or in a psychedelic startup or what have you, like how you want to define business. But we did just release an episode previously with a client of yours, Giuliano, and a really successful PTSD treatment protocol with MDMA, and we get into some interesting conversations with Kyle and some of his we talked to him about the FDA ruling last year and his feelings around MDMA assisted therapy, and he's very balanced, even you could say skeptical on that file. So yeah, I think it'll be interesting for folks to hear his approach and hear his feelings about that, especially in contrast to the last episode we released. Hopefully they complement each other on the not too tight, not too loose spectrum here that we're trying to hold,
Right.
trying
Right.
to hold skillfully.
What will become very clear to the listener is that Kyle is a big proponent of ketamine.
Mm-hmm.
And probably useful to give some context here because we touch on it briefly, that he's developed a protocol for ketamine therapy that really, I think, illustrates his brilliance and how he works, like how his mind works. And I should also say, he has a collaborator who's also just an awesome dude named Nicolas Garel, who's a psychiatrist at the University of Montreal. And together they developed this protocol called the Montreal model,
Mm-hmm.
a Montreal model for ketamine therapy. And it's just, again, their attempt to kind of incorporate or synergize conventional biomedical psychiatry and the psychedelic paradigm. And he'll talk about it in detail, but I think they do like 6 sessions over 4 weeks. They provide it in university hospital settings, and they've collected lots of data and published some really cool research with this model. And it's actually what we do at Refuge. And so hopefully that will help provide some context to when Kyle starts talking about the Montreal model.
Yeah, and the model it's called the Montreal model, but it's being used internationally. I mean,
Right.
increasingly, there's folks who came in, I think, over the summer from Europe and U.S. all over to learn the model and see how they're working. And that's another thing that I think that comes out in the episode that's exciting, is like there really is not just the Montreal model and the work that they're doing actually treating patients in the public system with ketamine, but the lab they have going, right? So
Yep.
Kyle's doing the work with Nicolas and ketamine, but at McGill, Kyle co-runs a lab with Michael Lifshitz. Is the psychedelics and contemplative lab, I think it's called, and just a really fascinating hub of activity that straddles these lines, right, between thoughtful research, clinical care, and also the edges of
Yeah.
you know, exploration of like what's going on in the mind, what's going on in the body, what's going on between all these folks in a room. And I won't spoil it, and we'll get Michael Lifshitz on hopefully in another episode to talk about some of his research. But yeah, just fascinating stuff
Yeah.
happening here in our backyard. So fun to chat with him about that.
Totally. I think one of the biggest takeaways for me is that the interview and Kyle's work, I said this earlier to you offline, it really feels like it's post-Renaissance. What I
Mm-hmm.
mean by that is he's not a big participant in the hype machine around psychedelics.
Yep.
He's also not ready to jump on the backlash bandwagon.
Mm-hmm.
He's actually interested in studying scientifically the healing potential of these substances when they're paired with adequate support.
Mm-hmm.
And he's working really like in the trenches, doing rigorous fundamental research, trying to test whether the assumptions that that come with the psychedelic paradigm are scientifically valid, if they're evidence-based, what we can drop, what is actually important to retain, like the mystical experience, how important is it really? This kind of stuff.
Mm-hmm.
So I just appreciate that. It feels very like up to date, up to the moment, very current, and just like really important, juicy kind of scientific questions that they're investigating and coming up with some really cool answers.
Yeah, and not just researching psychedelics, but researching everything else, right? So they've the setting work, right? So I think Kyle's part of a group, and they had invited a number of other academics, psychedelic researchers, thinkers, recently for a symposium to Montreal to talk about the social determinants of health and psychedelics. But really, a lot of these folks, and Kyle among them, and folks in his lab, advancing research on set and setting in a really rich, broad way. I think he makes reference to a paper they published this year, which we'll put a link to in our show notes, that polls tons of psychedelic researchers around like all the different like not just the room, not just the music, although Kyle has lots to say about music. But I think there are like 30 different factors, right? Really just trying to consider all the different variables that can go into whether someone has a positive therapeutic experience or a negative one, and approaching it systematically and thoughtfully. It's really important ongoing work, and glad that we get into it.
Yeah, and really like level set for the field so we can actually draw generalizable conclusions about these crazy interventions we're doing. All right, well, should we stop there and
Yeah,
let the
let's get
people
into it.
hear Kyle? Awesome.
Yeah.
So here we go. Here is our interview with Kyle Greenway. Dr. Kyle Greenway, welcome to Not Too Tight, Not Too Loose.
It is a pleasure to be here.
All right. So I was preparing for this interview and came across your bio, I think on the McGill website. And I'm actually just going to read it because it's really good. And then maybe we can unpack what's in there. Okay. And just obviously for context for the audience. So Dr. Kyle Greenway is an assistant professor in psychiatry at McGill University, he's an attending psychiatrist at the Jewish General Hospital and investigator at the Lady Davis Institute. He conducts clinical, naturalistic, and fundamental research on novel psychiatric interventions, particularly psychedelic-assisted psychotherapies for refractory depressive disorders. He leads the ketamine-assisted therapy service at the Jewish General Hospital, one of only a handful of clinics in the world to offer psychedelic therapy for severe depression in a public payer system. His work explores the impacts of extra-pharmacological factors on psychedelic and conventional psychiatric treatments, including how treatment protocols can be tailored to individuals based on their unique life experiences and cultures. Before joining McGill, Dr. Greenway completed postdoctoral studies at the world-leading Imperial College Psychedelic Research Center, as well as the McGill Clinical Investigator Program. So I'm impressed. I'm assuming you wrote that, or it just really captures in a way that many bios often don't, the scope and the depth of your work. So congratulations on all of that. Um, Maybe if you want, just give us your kind of potted bio of like what you do and anything you want to add to that.
Thank you. I mean, the fine art of academic humble bragging is something that one of, you have to sort of learn to thrive in this environment. Um, I mean, I think that captures the bird's eye view. A lot of my life is juggling the different hats,
Yeah.
and one of the most important ones that isn't reflected in the bio is that I co-lead a research lab with Michael Lifshitz
Yeah.
that we call the Psychedelics and Contemplation Lab, which touches on a lot of the things mentioned there, but also, especially his side of the lab, covers a bit more, let's say, extensive, similar but different processes you might find in the world at large, including prayer practices and different group social dynamics that both of us are very interested in. Uh, and then other than that, yeah, I mean, it's a balance between still doing some conventional psychiatry for hospitalized patients here at the Jewish, and trying to make time also to be a guide for some very, very often refractory cases in our relatively small program.
Right. So we're really glad to have you on the pod here, partly because Andrew and I both admire your work, but also because we feel you're kind of a not too tight, not too loose kind of person. And if that's a little bit esoteric or a little bit vague, I think it'll become clear in a minute what I mean by that. And we do want to get to your research because there's some really cool stuff happening there. I think for me, the best place to start is the Montreal model. This is your protocol for ketamine therapy. And I wonder if you can tell us about the development of this thing, basically creating this protocol in this clinic for public sector psychiatry departments. Just an incredible story, an achievement in and of itself. Tell us about the development of the Montreal model.
Yeah, thank you. I mean, that's one of the funniest compliments I've ever received. But not too tight, not too loose. I'll take it. I mean, the model itself is in some ways a bit radical and a bit intentionally, well, even maybe extremely boring in its conceptualization. Um, it evolved from clinical work mostly that Nicolas Garel, who's now a staff psychiatrist at the University of Montreal, doing very similar work but with a more focus on addictions. The model evolved from our collective experiences and working with many people treating very, very severe cases of depression, mostly at the Douglas, one of the McGill hospitals, and then expanding to the Jewish, starting almost 10 years ago overall now. And it's hard for me to put myself back in the shoes of who I was when we started this work, but I would say in a nutshell, very, very, very enthusiastic about psychedelic medicine. It's practically the reason I went into medicine and then psychiatry. And the process of developing this model was a painful process of learning by error, I would say mostly, and seeing what worked and what didn't work on the ground when you are actually dealing with people who would never, almost never be eligible for a clinical trial. So in other words, we tried to translate ideas and approaches that had been mostly developed in what might be called a somewhat worried well sort of population, finally manicured and given a whole lot of TLC in a very narrow clinical trial setting. We tried to apply that to people that were just living their life and often struggling for years, often in and out of the emergency room or psychiatric inpatient units. And, that gave us a great opportunity to see what actually works well and what really doesn't work well. And that's where a lot of the impetus from the model, for example, shifting from an emphasis on like thinking about the process of the treatment rather than the actual specific, say, mystical content mostly, and really emphasizing boring things like talking to people a lot about brushing your teeth and having routine in your life. And having a very strict sort of clear frame and protocol, and not as is really tempting in clinical practice to sort of adjust as you go with a little bit of a loose frame. And if you get worse, we're going to give more, et cetera, et cetera. All of these things kind of led to a model that we hope sort of spans the biomedical sort of approach of psychiatry, bits that I think are really important and really valuable, as well as like drawing a lot on the psychedelic literature and trying to land in something that actually works in the real world.
Kyle, I wonder if you can just take us on a quick tangent about your interest in psychedelics in the first place.
Yeah, I mean, I did my undergrad research for almost in the first day of starting undergrad, and then my master's in chemistry and physics, and that involved a lot of nuclear magnetic resonance, which is essentially like molecular fMRI imaging. And I had been fascinated by the emerging research in this sort of second or the revival of psychedelic research. And I just like it just struck me that there, in many ways, there are not many open frontiers in medicine, but this one was a big one. There so many interesting questions were being stimulated, I think, and so much reflection that goes way beyond psychedelics, like to the core of like what is the nature of mental illness and how do modern treatments work or not work? What is the overlap with cultural shifts, with big pharma, all that stuff? I mean, it just seemed like such a wide open frontier that actually had also the capacity to really help people.
Hmm. Hmm.
And I was exposed to severe and less severe mental illness around me for as long as I can remember. And so it was personal also to hope that, psychiatry could do better in some ways.
All right, thanks for that. Let's come back to the the Montreal model. I've heard you present on it and really appreciate the framing that sometimes comes up in your presentations, which is like you're kind of threading the needle between these two paradigms, the conventional biomedical, the psychedelic. Can you just speak to how you're bringing these two perspectives together?
Absolutely. I mean, I think this is something that we've thought a lot about because we've had to think about it.
Yeah.
Um, there, there are many ways in which the two paradigms are compatible, but are often framed as, diametrically opposed. And sometimes it's very subtle. And it just happens to be the quirks of clinical research, for example. So with the serotonergic psychedelics, people were often or almost exclusively are weaned off of their antidepressants beforehand, mostly for safety reasons. But it kind of feeds into this narrative that you find in the psychedelic space that like conventional psychiatry, SSRIs are just these kind of band-aid solutions that might work, but generally probably cause more harm than good, et cetera. Whereas psychedelics is something totally different. And, there's a bit of truth to those ideas, but I just think that it is not something that has to be. In other words, there's common mechanisms to psychotherapy, to prescribing antidepressant, and to psychedelic therapy that are, I think, woefully underappreciated. So that is something that is very common in our thinking, but also I would say, I've kind of lost my train of thought. Chuck, give me 1 sec.
Yeah.
Remind me of the question.
Yeah. Well, I was asking you like how you integrate these two paradigms, and
Yeah.
you offered this piece about how the psychedelic paradigm has this bias against conventional pharmacology, and then there you see these kind of we shouldn't take all these biases. Yeah, keep going.
Yeah. Thank you. Yeah. So I mean, in a nutshell, if you take a really really concrete sort of view of the way an SSRI works, that it's just modulating serotonin, a little bit like how insulin might be replenishing a needed hormone for people who have diabetes, you know, then it's easy to set up this kind of dynamic of not really seeing the similarities. But when you adopt a little bit more, I think, of a nuance or integrative view of how conventional psychiatry works, considering, for example, that every response to any psychoactive drug is heavily, heavily mediated by context, by the relationship with the prescriber, by your life circumstances, by your general feelings or views towards psychiatry or neuroscience, et cetera. Then you start to see a lot of the similarities with psychedelics. Psychedelics have been described in a little bit of a tongue-in-cheek way as super placebos. And that speaks to the idea, if you consider a placebo as a bit of a technology that converts a narrative into a reality, and psychedelics really do that, and they do that dramatically. But those same dynamics can be found in every psychotropic drug, including SSRIs. And it's one of these ideas that, in fact, when I started working with and clinically with psychedelic agents, well, ketamine, if we call it a psychedelic, um, it became something I became much more attuned to. And I started to see a lot of, I think, similar dynamics just on a much more subtle, gradual course with conventional psychiatry. If you remember from our Montreal model paper, I think we outlined 9 putative mechanisms. And there's really only two that I think are very distinct for the psychedelics. But there are seven that fit very nicely with conventional psychiatry, with psychotherapy, et cetera. Like simply interpersonal contact or becoming more interested in your own mental health and your own mind, exposure work, et cetera, et cetera. There's so much more in common, I think, than meets the eye.
What are the two from the psychedelic paradigm?
So one is that I think psychedelics provide a profound break in your day-to-day life
Mm-hmm.
that you might experience in a really powerful conventional psychotherapy session, but not really. I think we can agree that, somebody completely leaving the room or having a very mystical experience, et cetera, with ketamine is not that comparable to just like feeling really, really in a psychedelic session or a psychotherapy session. And then, likewise, I think although they're a bit kind of complicated and fraught concepts, spiritual experiences, mystical experiences, ego dissolution, awe, it's pretty rare that somebody walks out of even a great psychotherapy session and says like, "Whoa, my ego was completely dissolved on the chaise longue there."
For me, one of the best examples you give about bringing the psychedelic paradigm into conventional psychiatry is this traditional view of the subjective effects of ketamine, right? I'm going to caricaturize it a little bit, but
Please.
basically the story is someone comes in for a ketamine treatment, maybe for depression, I don't know, 20 years ago. And it's like, oh yeah, some weird things will happen when we inject this antidepressant into your vein there, but don't worry about it. You'll go back to normal in an hour or two, and then your life will go on, but hopefully you'll have the positive effects of this antidepressant. And you're saying, wait a second, guys, can we just be a little bit more sensitive to what's happening in that moment?
Oh yeah. I mean, we wrote this article called The Ketamine Chameleon that I think is one of the best things we produced because it took us years of going through all the literature. And what's really nice about ketamine is that it has both, it has like three distinct bodies of literature that overlap sometimes, but are relatively independent, which is, the biomedical psychiatric world, which is what you're describing, where ketamine is a dissociative. It's going to work for you because it modulates neuroplasticity, and you're going to feel a little bit weird, maybe really weird, but don't worry, that'll pass. It has nothing to do with the rest of it. And then, of course, there's the psychedelic world, which is very much oriented on the experience and doesn't necessarily denigrate the fact that there might be biological effects, but certainly de-emphasizes them. And then there's the anesthesia world, and that's very unique to ketamine, where in some ways you might think that anesthesiologists would be more concrete or more biological than the biomedical psychiatrists, but I think there's a strong argument to make that they're much less so. There are these incredible studies in anesthesia that psychedelic researchers would love to do in their own studies, like simply giving people different suggestions right before they receive ketamine in an anesthetic context and showing that a brief one-phrase suggestion can radically alter people's experiences of the drug and the tolerability. And also, there's an article from 1972 from Barbara Collier that is talking about people having, emergent spiritual experiences while receiving ketamine for anesthesia. And, it's just been kind of lost to history.
Mhm.
But yeah, ketamine, that's where we landed on this word chameleon for it, because it is remarkably flexible and dependent on context. And it's arguably, and I think this is the case, it's very possible to have a whole sort of paradigm evolve, like the biomedical psychiatry paradigm, that is unintentionally ruining people's experiences. And then basically concluding from those ruined experiences that the experience doesn't matter.
Yeah.
So a lot of our idea has been to grapple seriously with the idea that psychedelics do definitely enhance suggestibility. And small phrases, small ways in which you frame the drug that are different in one setting or another can have a really meaningful impact.
Yeah.
In the same way that an anesthesia saying you're going to have a positive dream or not can have a really powerful impact. So trying to find ways that like instill the idea that these experiences are potentially very meaningful without really kind of shaping them in one specific direction or another.
So it's actually super cool to hear you talk about this because you're not just speculating from your clinical experience, although there is some of that, but you're actually doing and publishing data about this. Okay, so I wanna talk briefly about um, the study that came out recently about set and setting, like the invitation to the field for everyone to take this stuff more seriously. And I just think you've got this amazing position in the sense of like you're in with you're at a McGill psychiatry department with people doing conventional biological psychiatry, but you're this loosening agent, inviting people to consider these other things and actually publishing. So maybe tell us about that piece.
Or am I an agent of tightening of the psychedelic space?
Also,
Who knows?
Both can be true. That's the idea.
That, paradoxes paradoxes are like the bread and butter of a lot of this work. I'll tell you the story of the respect guidelines that you're mentioning, because it's very simple. We did a whole clinical trial randomizing people to music or not for their ketamine sessions, mostly because I cannot believe that people are not even reporting whether somebody receives music in a ketamine dose or not. And that's the norm in anesthesia and psychiatry everywhere. And, we have seen people have transformatively different experiences with the presence of music or not, or even between music that resonates or doesn't resonate. And one of the findings from the music trial, the primary outcome was that the presence of music dramatically changes ketamine's effects on blood pressure, which is the number one tolerability issue with ketamine, according to many people. And so there's like it's a lot of work to show one little tiny graph, but the point of that blood pressure primary outcome was just to make a physiological case that set and setting mattered. So in a sense, my starting point for really becoming obsessed about how set and setting are considered or reported in clinical trials was saying, like, so if we have this evidence and you see it clinically that ketamine with music or not has different blood pressure effects, that has different sorts of emotional or spiritual experiences, it has different sort of impacts on people's psychiatric outcomes. Just as a researcher, even if you didn't care at all about psychedelics, I think it's easy to make the case that you just need to at least report whether music was used or not.
Mm-hmm. Mm-hmm.
Right? I mean, that's a very, very mild case. And, for example, the history of psychotherapy research is a history of gradually understanding better and better what are the things that need to be reported for a study so that anyone can understand it, so that you can reproduce it, so you can understand what worked or what didn't work, et cetera. Like you have to kind of shine light on the black box a bit if we want science to progress. So that's a roundabout justification for explaining where this idea came, which was basically just to try to establish a really clear state-of-the-art consensus on what of the many different sort of set and setting potential factors are so important that they should be universally reported. And that's what led to this study that was led by Chloe, who's now an R1 in psychiatry McGill, but we met in Imperial, and Leah Roseman and myself. And we asked 80 plus researchers, clinicians, and patients around the world to just start with listing 10 factors that they think are non-drug related, but definitely can impact the drug effects of psychedelics. And then through 4 rounds of iterative Delphi consensus debate, we landed on 30 factors that span what might be called set and setting, and range from everything from the presence of nature or not, music, of course, who's in the room, where the bathrooms are was one that I hadn't seen coming, but is actually very important to people. And then, a bit of the mindset sort of factors that we need a little bit further work, but come down to things like trust and alliance. If you don't have, the difference between somebody having a good alliance or a poor alliance with a psychedelic therapist is the difference, is an ocean of difference in terms of how it goes. So
Go ahead, Andrew.
I'm sorry. Yeah.
Well, I just it's amazing, and the thing that's coming up for me is, first of all, it's so funny to even be sort of having the starting point be, hey, set and setting matters, which we're supposed to have known for a very, very long time now, and yet, like you say, black box, like shine a light in the black box. My immediate reaction is like, how do you actually like begin to do that? And I love that you've done this work. Like, okay, well, here are the 30 factors, and I'm kind of tempted to like maybe we can't go into all of them, but maybe cover some of them. But then, how do you actually then begin to control for them and determine, like, with your, I'm not a researcher, but I know, you need to have a certain amount of control to be able, and there's a real desire to be able to show, hey, this is the mechanism of action, or this is the thing, these are the levers we're pulling to get this result. And I know you add one variable in there, it adds that much more complexity. You add 30 variables in there, like at what point does this become an impossible task, at least scientifically. I mean, you might talk to a
Yeah.
therapist or someone in an indigenous tradition or someone who has this sort of experience and wisdom and lineage of like, yeah, there's all these things you have to filter, and it becomes a bit of an art form. How do you marry that desire to actually consider all of these factors with an actual scientific approach?
A wonderful question, and like you can't get very far in this sort of line of thought without running into the limitations of double-blind RCTs, or at least placebo-controlled RCTs, randomized controlled trials. And that's because, yeah, if you really wanted to isolate a given factor, you'd have to do an entire trial where you held 29 of these ish constant, and one is randomized to one group or another, a little bit like we did with our music trial, randomizing people to music or non-music match support. But I think, what I'll say is that our ambition is far, far lower than what it might come across. The first ambition is just to report them, because if you look back at the literature and you try to disentangle, like, why did this trial produce 10 times better results than that trial? Or why did the old studies conclude independently over and over again that LSD is very clearly a psychosis mimicking drug, when then new studies very, very clearly conclude that, psilocybin is inherently mystical to some extent. You cannot possibly make sense of these conflicting findings without at least having a bit of information about what differed from trial to trial. And that's the first goal, basically. Just report the basics, guys.
It's so fascinating that the psychedelics are requiring of us to be much more sensitive to context and to actually have a conversation about what counts as context. I know when
Mhm.
I was an undergrad, I had to go and do like volunteer as a research subject in like some studies and labs and stuff to get,
Mhm.
credit or whatever. So I'd go to like the psychology lab in the basement of the building in Toronto there and like do some task. And, in the paper about that study, they didn't say the color of the walls was off-white. The chairs that we were sitting on were made by IKEA. There was
Mhm.
two people in the room. One was like, at a certain point, we draw a consensus around like what are the key factors that you have to report. Like, the color of the wall is not relevant to my IQ. We all agree, but these substances are making us reckon with, okay, what actually counts as relevant context here? And it's like super complex, right? What do you do?
But I will say, because you're talking about like an IQ study, right? I mean, as you made reference to, and there are these incredible examples where simply having your phone on the table or out of the room can drop your IQ by 5 to 10 points. Or
Right,
for
right.
people that are from racialized groups, being asked to state your ethnicity on a sociodemographic form right before you do an IQ test can also drop your IQ significantly, according to the test. And so, the fields, all fields are learning over time, like what actually matters.
Yeah.
And, research from the 60s, 70s, that's obviously not when you did the UFT study, but, old research decades ago, there's in every field, the methodologies were poor. But you're right. Like basically psychedelics, that's one of the exciting things about them, I think, is that psychiatry has done a fantastic job ignoring context for
Yeah.
decades.
Yeah. Yeah.
And it's like psychedelics hopefully will force everybody to grapple with the importance of context, even if you don't actually end up doing anything regarding psychedelics in your
Yeah.
career.
So this is one of the things I find most remarkable about your work is that you get these considerations on the loose end, but you're also publishing in very mainstream journals. Because to do that, you do have to decide and move ahead and ask certain research questions, and you're erring on the basic side, right? Which is as far as I could tell, like a really smart strategy. I wonder what else you could tell us. Just what you published and what you think stands in the literature at the moment as like important stuff for us to know about these interventions.
This is a dangerous question to ask a researcher. This really, but I'll give you a couple recent ones that we're very proud of, and I think are criminally underread, if I may say so.
Is that a humble brag again, though, Kyle? Or
Yeah, there it is. I told you, this is an art. Uh, Well, I mean, we just published an article in the British Journal of Psychiatry that is a culmination of many, many years that is essentially showing that when you administer ketamine in the Montreal model, even to people that are incredibly refractory, people who would never be in other clinical trials, some with bipolar disorder, some with psychotic symptoms in the past, et cetera. And, you can still do it in a psychiatric hospital, and the settings were not perfect by any means. But with some careful attention around preparation, with blindfolds, with music or non-music support, people can have powerful experiences, both emotional and mystical. And these are the results of the music trial I'm speaking about. I mean, they are important for a few reasons. So one is there is this idea that ketamine is not a true psychedelic. It doesn't cause the sort of spiritual or powerful experiences that psilocybin does. And we've shown just, that is not the case, even again, in a very, very severe population that is not prone, I think, to such experiences naturally. Um, Interestingly, because we had 6 doses of ketamine in our protocol, because ketamine is quite short, rather than 1 or 2 longer doses of psilocybin, we could do some really cool statistical analysis and show on a session by session level that a more mystical experience at a given session was related to a relatively greater chance to improve in depression at the next session. So over 180 doses, you can kind of daisy chain these analyses and make a very strong case that the experience matters and that certain kinds of experiences, captured by the mystical experience questionnaire are particularly beneficial, which is like such a fun finding because there is still debates even with psilocybin, but especially with ketamine about whether the experience matters at all, except for maybe tolerability. And interestingly, another finding from that study that was is kind of fun in hindsight is that the emotional breakthrough inventory, although it showed relationships with benefits, they were unidirectional. So they were bidirectional rather, which meant that as people's depression improved, they also started to have more emotional experiences, and it suggests that surprisingly, that questionnaire is probably not causally related to benefits, whereas this was not the case in the mystical experience; it was a unilateral direction.
Mm.
So
So people that had a mystical experience were more likely to respond to the following ketamine administration session?
rather, people who had let's say, a more mystical experience at
Yeah.
treatment 3, for example,
Yeah.
were more likely to show up feeling better at treatment 4. And then if at treatment 4, they had a less sort of mystical or powerful experience, they were less likely to show up with improvements at treatment 5.
It's a kind of a nuanced thing. Does the study not show that the intensity or proclivity to have a mystical experience predicts treatment outcome? Is that not the case?
Basically, because we did group level analyses, which just show in general, like if you take a given person, somebody who has average higher scores in the mystical experience questionnaire, or had a high peak score, so even one experience that was very mystical for them, those people do better overall on
Hmm.
every outcome. So that's easy. But what I'm speaking about is as a more sophisticated analysis that used the 6 time points to really examine at a fine grained level whether there was a causal relationship. Because those are the group findings are a bit of, correlation is not causation
Mm-hmm.
sort of
Mm-hmm.
problems. And that's where the attacks of methodologists on the psilocybin literature say, like, it's great that people had more mystical experiences tend to do better, but you don't know which way that
Mm-hmm.
causality goes.
Mm-hmm.
But by having these 6 doses and going with a pretty sophisticated analysis, we're able to make a very strong causal claim that it really was having those experiences that produced the benefits and not benefits that produced the experience.
Andrew, did you have something there?
Just
Go
to
ahead.
say, Roland Griffith's mystical
Yes.
experience were vindicated.
Well, actually,
Yeah.
Kyle,
Or no, I
what
don't
do
know.
you say to that?
I mean, it's funny because,
Yeah.
especially when I put more on my, say, transcultural hat on, because we're deeply embedded in the McGill division of transcultural psychiatry, the mystical experience is fraught. And it's complicated. It is way more culturally dependent than one would, possibly sort of guess from reading How to Change Your Mind, et cetera, or Johns Hopkins, I think, early work. So I was a bit annoyed, actually, in some extent, by how freaking powerful as a predictor the mystical experience questionnaire, as it is, was in our data. And it's remarkably powerful. I mean, like extremely high correlations with benefits.
So
So
I've heard you.
it,
Yeah, go ahead, Kyle.
I would just say, I mean, it still opens up to questions. Like even if you have kind of a poor questionnaire, but it's capturing, let's say, something that might be better termed ego dissolution or awe, it could still perform very well. It doesn't necessarily validate the underlying conceptualization of the concept. Like our results, I do not think attest to like that the Hopkinian definition of a mystical experience is exactly correct. I think more research is needed, and it's probably not correct in some ways. But it does say just something about like these sort of powerful, ineffable experiences that we all struggle to put words on do definitely have benefits potentially.
I love your bit about how, if we're sensitive to context and like
Mm.
in around these clinical trials or this research stuff, and then psychedelics are like, make us orders of magnitude more sensitive. I love your bit about like Roland Griffiths walking through the lab and like popping his head into one of the psychedelic rooms and like, hey, did you have your mystical experience yet? Did you have your mystical experience? And then just like really overdoing the expectations, um, making the results of the studies, ambiguous, let's say. Um, it's so interesting. Again, you're doing all this work at a very particular time in the history of these substances and their collision with our society, and here you are kind of wading into this literature and doing the detail work, the empirical work about like what is actually going on here. And so cool that you're actually digging into the Roland Griffiths thing. And I don't know if this is a fair compliment to you, but like you, as you say, you were sort of hoping to like to show that the Johns Hopkins stuff was sort of methodologically unsound, but here's something like his results showing up in your data.
Well, I think we've swung a few different ways. When we started, it was very much directly inspired by, arguably kind of simplistic narratives around like you take a psychedelic in sort of satisfactory conditions, non-directive guide, non-directive music, a mystical experience emerges mostly spontaneously and you get better. Like definitely when we started, we were trying to make that work. Uh, and when we talked about the Montreal model earlier, one of the things we learned very quickly was like having a mystical experience in and of itself that was absolutely not going to make you better if you were spending, let's say, your entire life in your bed.
Mm-hmm.
Like the experience matters, but there's also, behavior, toothbrushes, these things matter too. But then, yeah, indeed, I think um, the results that we have found in the music trial for that questionnaire, they show that even though I have many critiques and complaints about it and about the earlier research that it's based from, those critiques are I guess relatively mild. Mostly we're talking about fine tuning, I think.
Mm-hmm.
Um, when you compare, for example, with I think a preposterous idea that like, oh, the experiences just don't matter.
Mm-hmm.
That's an order of magnitudes more incorrect, I think.
Kyle, can we do another quick detour here? I think we're underselling a little bit the really fundamental, basic behavioral and psychological interventions that are part of the Montreal model. Like obviously, here we are, like everyone else, fetishizing the ketamine. But tell us what are some of the things that you do or that you ask your patients to do while they're going through your program.
Yeah, I think one of the most important things is right up front and all throughout, we try to adopt this position that the treatment is going to be active.
Mm-hmm.
And this is one of these places where I think psychedelic psychiatry has maybe unintentionally reproduced some of the harms of conventional psychiatry. So the way I would summarize this is basically, when conventional psychiatry goes wrong, people with depression, which is basically almost always characterized by excessive passivity, are told that the answer to their depression is to basically passively receive a pill on a daily basis. That that can work, but it almost works in spite of that idea if it does work. Um, where psychedelic psychiatry, I think, can go wrong also is this idea that you just have to passively receive an experience. Again, it can work, but I think it's really, almost in spite of the bad idea underlying it that it does work when it does. And so in our model, very clearly upfront, we make the case that ketamine can be very helpful as a catalyst, but there has to be a therapeutic process really coming from the individual themselves that the catalyst is going to accelerate. Um, and that looks like, again, I keep coming back to toothbrushes, and this is a bit funny for me because the more I reflect on the trajectory so far, the more I thought that, like, I started thinking that you know ketamine was the Trojan horse into psychedelics for the field of psychiatry. And the more I think about it, the more I think that psychedelics are the Trojan horse for thinking about people's hygiene in psychiatry. Because yeah, we ask people to establish 3 SMART goals. Very simple, but it really sets the tone that, like, you are going to, get out of bed daily, or add a little routine in your life, or if you're already a little further ahead, add some exercise or work on your sleep hygiene. And you're going to show us that you can do this before we even schedule a dose. And that's because, if you're not able to do those things, if you're not willing to really push yourself, we've learned the hard way that there's just no hope for the psychedelic intervention. It's just not the right time, or it's not the right fit.
Oh, we were
Oh,
joking last week that the that work that you're doing and the work that I find myself doing a lot in psychedelic integration with,
mm,
albeit a very different population, looks very similar, right? In terms of
mhm.
Mm.
wanting to plant the seed for sustainable, like long-term positive outcomes. It is more about those habits, and there's some direction there, right? I think that one thing that you're naming that's interesting is we were talking about the mystical experience and that sort of that first wave, if you will, of the model for understanding psychedelic assisted psychotherapy and mechanisms of action. This trust, let go, be open. You have the experience,
Mhm.
and the mystical experience comes as a result of some kind of divine inner healer that you're then experiencing passively, and maybe that's where the not too tight, not too loose piece comes in, right? Well, like there may be something mystical and beyond that you're experiencing. There's nevertheless there's some real structure.
Yeah.
There is a real outer healer telling you, hey, you need to be thinking about
Yeah.
this and this and this. And how do you find that line, right? Because and I
Yeah.
wonder about,
Yeah.
again, going too far there, where you can have folks who are like, okay, tell me what to do, tell me what to do. How do you then build that capacity up so someone is able to, you know, um, be past, like, to take care of themselves, really?
Yeah.
Like, how does that,
Wonderful
how do
questions.
you do that? How do you do that handoff? How do you actually get folks who are, when you're working with some refractory populations and folks that are really have a hard time, what are you seeing in terms of people's ability to then build more capacity and improve their lives in a way that isn't reliant on, let's say, on so much external structure?
Definitely. I mean, these are great questions. And, I've talked about prescribing and where that can go wrong. But, even conventional psychotherapy obviously has had a long history of cultivating excessive dependence on therapists. Especially when there's money changing hands, it can get a little bit messy. Um, but yeah, that's where there's no simple answer, I think. But what we've landed on is, I am going to insist that I have 3 clear goals that are established, but the patient is the one who's going to establish them. I can provide some input regarding, the relative benefits of, say, exercise or sleep or meditation, etc. But those have to come from the person. And, it wouldn't do anybody any good for me to tell somebody how to, like, specifically change their life. They really have to decide that. But it's sort of, I think, our role to make clear, like, that it's not about doing everything you should be doing right immediately. And it's not about, doing basically nothing and just waiting for the ketamine to fix you. There's got to be that sweet spot. But that's another part of our model that I think is really important to us, is wherever possible, we really want people to be agents of their own treatment, of their own change. So when it comes to music, for example, I think it's a good example where psychedelic therapy has kind of carried forward some outdated ideas about, for example, the idea there could be one playlist for psychedelic therapy, the great playlist. Whereas for us, it's way more important when it comes to music that people actively choose what music they want to use. Even if it's simply saying, I'd rather have that playlist with less vocals, or I'd rather have this playlist with, more of an emotionality component. Um, because, it speaks to the fact that they are ultimately in charge of their own healing. So I think the role of a good clinician in general and a psychedelic therapist, et cetera, is basically to, create a structure, create a frame, create some sense of accountability, create a real relationship that kind of glues all that together, but also make a lot of space for people to find it in themselves to get better than, get better on their own accord.
I'm hearing you. Um, this sounds a lot like what I was trained to do in the MAPS trial.
Hmm.
Um, I don't know if they call it inner-directed, right? Inner-directed psychotherapy. Like the whole point of the training was to um, untrain us away from our old habits of being sort of more actively involved, and really just stepping back and being a container for the person to do their own work. Um, and yet Andrew made this slight, this reference to the inner healing intelligence as something, maybe limited about the MAPS model. Um, we talked about Johns Hopkins. We got to talk about MAPS. What's been your, following them? What's been your relationship to their work, and what is contributing, and what its limitations are?
Yeah, I have great questions. And Maps, I was initially very, very, very enthusiastic about it, and I have to say there are many ways in which I think a lot of us have been disillusioned to some extent or another, at least about the current incarnation or the recent incarnation of the movement, of the research. Um, I think on a theoretical level, when it comes to like the therapeutic approach, absolutely. I think the Maps manual is extremely humanistic and very much, encouraging, yeah, therapists not to be overly directive. And I think those are important points in many ways. I think there are small problems that turn into massive problems. Like conceptualizing music as a non-directive force in the therapy is in my mind ludicrous. It's just ludicrous. I mean, people are it's basically a sensory deprivation state, right? With blindfolds and headphones for most of the session. And like, again, it's most of the session. And the music that is used is often super evocative. It's not like, light piano medleys in the background. And the idea that that is not super directive is crazy. And so if you just take that little example and you grapple with the consequence of that, then you have to do away with the idea that we can just be passive and that an experience emerges kind of spontaneously. And you have to admit that no, there's no such thing as passive in that context. And your music choice matters a lot and is directive. And there are meaningful consequences for what you do with that sort of reality, I think. You know? It's harder in an 8 hour, session than it is with a 45 or 50-minute ketamine session that then we have multiple doses where you get to really engage people in choosing their music. And so I don't know exactly what I would do if I was, say, in their shoes designing their therapist guide, et cetera. But it just kind of irks me that there's this, I think, very obvious misconceptualization there. And I think that speaks to how good intentions plus maybe a bad idea or two can really can go off the rails.
Mm. Off the rails, eh? What do you mean by that?
Well, I mean, when the inner healing intelligence works, I think for a given person, it's because it really says like you are not as broken as you think you are.
Mhm.
And you don't need me to fix you. You don't need the drug to fix you. You're going to fix you. We're just going to create the circumstances for that to happen,
Yes.
right?
Yes.
This is very similar to stuff that we believe. Um, where it goes off the rails is, for example, somebody has a challenging experience.
Mhm.
And, indirectly or directly, they're basically led to believe that it's because their inner healer is distant or broken, or they didn't do something to allow the inner healer to take the wheel and lead them to recovery. And, that can basically add insult to injury. You had a bad experience, you feel worse, and now you've walked away with a feeling that you're even more broken than you thought you were. And then likewise, even when it goes well, there's, I think it's not clear for people why it went well.
Mhm.
And that also, I think, is not the way to a sustainable model of care. Like, I think when people get better in psychiatry, ideally they have an accurate understanding of how they got better, what made the
Mhm.
difference for them. Because the natural history of depression, for example, is, it relapses. And so even if you help somebody and they're doing well now, if you've also given them incorrect or kind of, maladaptive ideas about
Mm,
how you help them, you set them up for further episodes, and it can actually create a bigger problem in the long run.
right. How do you
I'll just say,
yeah, go ahead.
sorry, go ahead. Go ahead, please. Yeah.
How do you conceptualize difficult experiences in your program? Or how do you help your patients conceptualize difficult experiences in the program?
I think there is some truth to the idea that there's no such thing as a bad trip. There's only challenging experiences, and we can learn more from those than good experiences. I think that can be true. And there's also a very real possibility that, usually set and setting is off, causing just a bad experience. Like you can definitely just have a bad experience that teaches you nothing, you know? Especially regarding the actual experience itself. So, for example, somebody who, this is the case that's in my mind. Somebody who didn't really, well, actually, straight up misled us about actually planning on going back to work in the afternoon after a morning ketamine session. Had a very bad experience. And there is nothing about that experience that I think in and of itself was
Mhm.
meaningful. Except if you zoom out a little bit and you say like, okay, what does this tell you about, the way you're prioritizing or not your mental health, or about maybe the fact that, if you really cannot take an afternoon off work for like this work, it probably wasn't time for this work, or maybe your job is really more problematic than we realized. And then it also speaks to something about how, the fact of needing to sort of mislead or present a false narrative to a therapist. Uh, that is classical, like good material for conventional psychotherapy, right? A lot could be learned there. So, I think in that sense, I'm saying that, even though that's sort of a set and setting mistake that leads to a bad experience, there is a lot to be learned from the overall trajectory, but it has nothing to do with whether or not you had a near-death experience or you panicked. It has everything to do with zooming out a little bit and understanding why that experience was what it was.
So it's just more grist for the mill. It's not
Yeah,
something wrong with you fundamentally as a human.
totally. I think that if there's something I appreciate about the inner healing idea, it's that, the sense that nobody is really broken, that we are all damaged, and we all also have the capacity to get better.
Mhm.
And I think if you're doing any sort of healing work in medicine or mental health, like you really have to believe some iteration of that idea.
Yeah, yeah,
Otherwise, what gets you out of bed in the morning?
yeah. So yeah, I mean, these issues started to accumulate for MAPS, right, as they approached the FDA application. And
Mhm.
ultimately, it didn't work out. I definitely want to hear your take on that. But we have, I think, you just spent a week
Hasn't.
with, what's that?
Hasn't is maybe a better word than yet.
Right. Thank you, Andrew.
Yeah.
Thank you.
Yet.
Um, I think we
We're also using the
also,
word. We're also saying using the term maps, which I think is fair in terms of the
right.
It's
legacy
outdated.
clinical in terms of the
Yeah.
legacy sort of research and clinical applications. But maps became Lycos, which is now Resilient. I think is the name of the drug company now advancing or attempting to advance.
Don't worry,
Yeah,
Andrew.
yeah,
We're going to get to MAGA. Don't worry. I promise we're going to get to MAGA.
great.
um,
Oh.
so we have to spend a little bit of time on Symposio because you just spent a week with Nishay Devino, right? What is your take on, this? You called it a movement before. MAPS is chugging along. The clinical trials are showing these amazing results. And then something happens. There's this backlash taking shape, and Symposia being a big part of it. Um, what's your understanding of that period? And, now that you've got this like really deep, intimate view on it through your relationship with Nishay, I'm just so curious what you learned from that.
I'll say that I think one of the major themes for me about where politics has gone awry and our decision making at big scales, whether it's for FDA regulation or therapy designing or corporation, whatever, is when we focus too much on individuals. So I say that to say that basically I will gently refrain from commenting on on an individual. I mean, I shouldn't have talked shit about Roland Griffiths actually, but because I think what I understand from the bird's eye view of what's happened with say maps and symposia is that very complex issues in at their worst have devolved into character assassination attempts. And that is a tragic story for me about human beings in general. Um, like you see Justin Trudeau or Obama or whatever, being personalized as the single face of a massive machine. And then often it can just evolve into, yeah, as I said, name calling, etc. Um, I think I think what struck me most about reading symposia over the years and also a lot of the having contact with maps is that uh, I have made many critiques of maps in private or public that are kind of similar, I think, actually, to
Mhm.
what that got symposia labeled kind of person non grata. And it's interesting to think about why that's the case, because I think very quickly the debates moved away from substance and
Mhm.
moved to noise. So anyway, all that to say, I think that basically, in an ideal world, science is about moving forward, testing ideas, and learning from mistakes. And in our music trial, for example, we really thought that the music intervention would be superior to the non-music intervention for psychiatric outcomes. In addition, those are our secondary outcomes, and we were gloriously wrong about that. And you want to live in a world where being wrong is a good thing because that is where new knowledge lies. And unfortunately, I just think that that is not the world we generally live in. Um, and when there's money involved, it's certainly not the world we generally live in, uh, at scale. And, there are so many lessons that could be learned from the last 10, 20, 30 years of research in and around psychedelics that are just not being learned. They're just leading to more entrenchment and doubling down and character assassination and stuff like that.
Hmm.
Um,
I wonder,
I think.
so Joe's alluding to the last week you spent, but um,
Mm,
you invited a bunch of folks to Montreal for a
yeah.
symposium on the social determinants of health, and hosted this event at the lab at McGill. Joe and I were able to come for that roundtable at the end of the week. I wonder if you just want to, speak more generally to that group that you gathered for this. Was a symposium? What were you did you, or a small conference? I don't know how you name it, but if
Yeah.
you just tell us a little bit about, yeah, who you invited and why, and what you guys got up to, and sort of what might have emerged from that gathering of minds.
Yeah, yeah, that was a really special event for us. One of the loose threads from the Delphi project was this idea of social determinants of health,
Mhm.
um, as a concept that obviously matters a lot for psychedelic experiences and for psychedelic research and probably for all of psychiatry, but was too vague or too complicated to really include in any meaningful way in the actual guidelines. So it was, and it didn't reach consensus threshold. So it was kind of left as this open question. And we got some funding from Healthy Brains, Healthy Lives at McGill to essentially bring in some brilliant folk from all around the world and spend 3 days in a workshop together, trying to flesh out better, what does this term even mean? The social determinants of health. Um, how can we do a better job in psychedelic research? How does it overlap with the concept of set and setting? And, this was a really fun conversation because we intentionally invited people that span from, those who are really interested in like actual implementation science. Like, how are psychedelics going to help people on the ground and not just the sort of, wealthy people, wealthy, educated people that find themselves in a clinical trial? And it spanned to people who are just like deep thinkers. Like, we had people who are anthropologists. We had multiple anthropologists who have immersed themselves in ayahuasca ceremonies and really seen the ways in which the cultural context shapes the experiences. And I don't want to name names. But we had people from across all the ideological spectrum, from people thinking that psychedelics basically are like very, very important and also shouldn't be really left in the realm of psychiatry, to those thinking that the biomedical sort of approach to regulatory approval is the way forward. And what can I tell you we learned? Well, you know, great question. I think one thing we learned is that, again, if we just have a little perspective, things are done so badly right now. There is so much room to do better. So, so like the most simple conceptualization of like what are the social determinants of health would include something like socioeconomic status. You know, that should be reported universally in a trial so that you have a sense of whether this is just affluent people who were able to take weeks off of work for their study, or whether this is like really the kind of people we meet mostly in psychiatry who are often disadvantaged. It's reported like almost never in modern trials. It's pitiful, really. And so that's kind of exciting because we think that's a place where we could actually just do better. You know, there are questionnaires for a whole bunch of important social determinants that just should be routine, a little bit like we hope the set and setting reporting guidelines, the respect guidelines become routine. And then on the opposite side of the spectrum, you know, like set and setting and social determinants of health overlap so closely in terms of the like recognizing the importance of context. You cannot understand how somebody's brain lights up or doesn't light up in an fMRI scanner, nor how they respond to a given experimental treatment or not, psychedelic or not, without knowing much more about who they are. You know, and it's kind of a beautiful view. It causes lots of implementation questions, but this is very much, for example, like the person-centered view I think you find in transcultural psychiatry, that like you just have to really, there's no shortcuts. You have to take your time. You have to
Mm.
understand and give an individual's life world, their background, their ideas, etc., to know anything about what neuroscience or psychiatric studies are going to actually find.
So, Kyle, what was your reaction when the FDA rejected MAPS's proposal?
You know, I think there are things that I've mentioned that I find sort of flawed in the way the therapy is conceptualized in the in the PTSD sorry, MDMA assisted psychotherapy for PTSD approach so far, like the inner healing intelligence. There are things also that I think are not good in terms of clinical research methodologies. So in general, approaching these therapies as if they were a drug therapy plus X, Y, and Z, I think is the wrong approach. I think they should generally be approached as a psychotherapy plus a drug,
Mm.
because then you would see that a lot of the very basic standards now for psychotherapy research haven't been met.
Yeah.
You know, and then, beyond that, I actually also have problems or worries, let's say, about MDMA as a specific agent.
Mhm.
And so I'm fearful, to be honest. I don't think, especially if it's rushed, I don't think unleashing this in the current healthcare structures, especially when it kind of goes, off label, et cetera. I don't think that's going to be a net positive for the world, sadly. So I was happy in the sense that I think it needs more time, but
Mm.
who knows now? I'm not, I'm not sure this reality with probably a rush through approval coming in the next near future. I'm not sure that's better than an approval in the previous regime when it was rejected.
So you don't think it just needs more time plus Elon Musk?
Again, Elon Musk, I will not comment on because I value my life, but yeah, what it needs, I think, again, is like something that I don't know we can pull off at scale.
Mm.
It needs like some reconceptualization. It needs like some thought, some careful thought about how the model as is going to play out in the real world. I mean, if you just simply ask the question, is it going to look more like these horrific examples of people really being harmed or in sometimes grotesque ways? Or is it going to look more like the really wonderful examples? I mean, the answer is we have no idea. But there's a good reason to think that it only gets worse when you release something from a clinical trial into the wild. We have very good evidence that that is the case with everything in psychiatry, really. You never find a treatment works better, I think, in the real world. Anyway, and like, I just don't think there's any satisfactory answers to how the training, the supervision, the
Mm.
resources, the unfortunate dynamics where there's, for-profit incentives to do bad care. I don't know. I don't think we have any reassurance that this is going to work in favor of the world as a whole.
So super interesting idea to treat it as a psychotherapy plus a drug. Although, how do our institutions even begin to evaluate that? I wonder what other, I mean, obviously you're welcome to pick that one up, but I wonder what other innovations you'd recommend in terms of studying this stuff so that we can get it across the finish line in a way that's safer than it would be in the next 12 months if you're RFK Jr.
Yeah. I mean, I think, I guess when I say that, I mean mostly at least have the sort of clinical trial design standards that we've carefully produced for psychotherapy research. Um, but, in general, again, I personally don't believe a double-blind,
Right.
placebo-controlled RCT makes any sense with psychedelics.
Right. So what do you do?
Yeah. So what
I
do you
mean,
do
let
indeed?
me say, like, I
Test it out in the real
fundamentally
world.
believe what, Andrew?
Well, test it out in the real world, right? If it's not,
Right.
I wonder if you
I
can have both
fundamentally
of those
believe
things.
that these substances, including MDMA and ketamine, um, have the potential to profoundly improve the lives of many people. Is there the risk that it profoundly disturbs or disrupts other people's lives? Yes. And so these substances have to be brought into our society in a careful and safe way. But um, there's a risk to not allowing people to use these substances, or a downside. And I'd like to see us get there. So, what do you think we need to do?
Do you know the story of, and I'm forgetting which senator, but there's a story that a senator's daughter took LSD and committed suicide, and that this story was passed on directly to the president's office during the
Yeah.
first wave of psychedelic research over and over again, and was again like this a great example of how taking a massive thing and turning it into one person
Mhm.
led a massive backlash that might have been the decisive blow to the first wave of psychedelic research. And also, by the way, turned out to be totally false, that LSD was not involved. The person hadn't taken it for months and it was a suicide, whatever. I mentioned that because I think even if one really believes that on the whole, without adequate or like without perfect systems in place, that these things will be a net positive, I think there's good reasons to think that it's also exactly how you end up with a backlash that puts us even further behind than we are now. Just putting that out there. Because, yeah, Andrew, as you said, I mean, like, inevitably you have to learn from real world experiences. There's no way to predict in advance, and none of us know exactly how it'll play out. But I think there are more forgivable, drugs. I mean, I'm biased as a primarily a ketamine researcher, but I just don't think ketamine is as problematic by nature as
Oh,
MDMA is.
So,
really?
okay. So,
Yeah.
I mean, and Kyle, can we like let's talk about that then, right? Because
Yes.
ketamine is out there, especially
Yeah.
in especially in the US,
Yeah.
off-label, being shipped to people to inject themselves in
Yeah.
their homes. Like, is that a good thing? I mean, you know, yeah, is that a
No.
good thing? No.
No, it's not a good thing. Definitely not. But if you try that with psilocybin, you'll learn within hours, So I guess like in some ways what I mean is, I guess that's the downside of ketamine is that it is very forgiving in many ways. You can do crappy Zoom therapy with somebody and ship them a dose of ketamine, and you might have the misguided idea that it's okay for a while. And if you do that same thing with like shipping somebody an LSD tab or some MDMA, you probably learn within like literally the first session that this was not a smart move. So I think in a sense, ketamine is the dangerous one because it can lead bad ideas to propagate unchecked a bit. But on the whole, ketamine has an incredible safety record. Like it's been used in medicine for decades. We know this drug very, very well. We know the addictive potential. It's not sugar coated. Whereas it is for a lot of other drugs, even cannabis, for example, like the fact that it can cause tolerance and dependence is still like really not known at the population level. Um, anyway, I just think that in general, like the idea, like I mean, MDMA is particularly challenging for the sort of interpersonal dynamics that it creates that require, I think, a very careful therapeutic frame and very careful structures and are prone to, unfortunately, causing abuse, I think. Abuse from power dynamics, abuse, sexual abuse, even. There's something about MDMA pharmacologically that does that. That is, you don't find it, I think, with psilocybin and ketamine. And I'm worried about it. I mean, I think there's already these horrific studies that something like 3 to 5% of therapists with no psychedelic whatsoever involved will report sexual transgressions with clients. Like, what happens when you take those therapists and you give MDMA to them to dose their clients? Like, honestly, it could be a freaking disaster.
Kyle, not everyone, a lot of people that I talk to, when I tell them that I'm doing ketamine assisted therapy, They look at
Mhm.
me like I've gone off the deep end, because their reference for ketamine is what like their kids are doing at the club, or like just how popular it's become recreationally. A friend of mine went to
Mm.
test. He wanted to go dancing, and got some MDMA and like brought it to one of like the safe testing sites in Montreal. And the person was saying that like they're seeing so much ketamine, it's like it's crazy how much it's kind of like racing up the charts of the drugs they're testing the most. Um,
Oh God.
yeah, and there's these again, not to make it these stories about one person, but like the Matthew Perry thing, like this really worries me because of the therapeutic potential. But again, are we going to end up in some kind of like 1970s style backlash against ketamine?
I I challenge almost this idea that it's more forgiving. Like I'm not saying we should be shipping people LSD for, to
Mm.
like to manage their clinical issues on their own at home. But I could also see a scenario where it's like, oh, I had that experience. I'm not going to do that. I'm not going to do that again. Right. Or
Yeah,
maybe
yeah,
maybe it was uncomfortable, but I
totally.
really learned something, and I'm not going to do that again for a long time, if ever. Versus ketamine, which is like, do it again, do it again, do it again. I don't
Yeah,
know. I don't know that
yeah.
and like I think situating it, to me, like situating it in the broader context in terms of like what is accessible already anyway. And it's true, ketamine is just everywhere. And
Mhm.
maybe that is a byproduct of the psychedelic renaissance and ketamine's sort of unique position in terms of being available off label and et cetera, et cetera.
Well,
But
this conviction or this belief people have that because it's an approved drug, it must be safer,
Mm.
right? Which ketamine has, and it is comfortably and safely inside of the biomedical institution.
Well, I mean, physiologically, it is remarkably safe, and that bit is true. And when I say forgiving, I guess I mostly mean in terms of set and setting.
Mm.
Like again, we've given people ketamine in inpatient wards for their depression, and it's worked well. And you will never that will never happen successfully, I think, with like LSD or MDMA. And yeah, I totally agree that that is actually it's unclear if that's a feature or a bug in the context of spreading recreational use. But yeah, I don't know. I don't know. I guess there's no single metric of what's worse or better. I I guess I think that the ketamine genie is out of the bottle.
Yeah.
I really wish it wasn't. I mean, I don't think the recreational movement is doing anybody favors. And like it's endemic in Hong Kong, and it's possible that the rates go way up here. And the same lessons that we could have learned from the opiate epidemic are really just repeated, unfortunately, the same errors rather. Um, yeah, but in that context, like, there's no world in which we get rid of ketamine. It's so essential
Right.
in medicine.
Right.
They literally in the 1970s and 1980s and then again 1990s, like the developing world pushed back at any WHO classification of ketamine because they need it for resource poor countries. So anyway,
Mm.
ketamine's not going anywhere for better or worse. So why would we add MDMA and
Mm.
LSD and psilocybin into the mix? It's not like it's going to correct the problems of ketamine.
Let's talk about psilocybin for a second, because doesn't have the same addictive potential as far as I understand. Um, Maybe not as forgiving to set and setting. Like it, I wonder if we're pulling out features and bugs. It actually lands,
Yeah.
it comes out pretty good, no?
Yeah, yeah. I mean, I do think that if there's one agent to be really helpful about it is psilocybin.
Hmm.
I think, it has a lot of the benefits of, I mean, as you say, yeah, like non-addictive, I think is mostly true. Um, Although you will find people talking about real addictions to classical psychedelics that seem to buck against that notion a bit. But yeah, I mean, I don't think it gives rise to the unfortunate kind of interpersonal problematic dynamics that MDMA does.
Yep.
Uh, it has the benefit again of being very safe, much safer than MDMA in a physiological level, I think. I mean, not as safe as ketamine on a psychological level. So yeah, it straddles the two in many ways, and
Mhm.
yeah, I'm way more optimistic for psilocybin rolling out in a way that is more beneficial than harmful.
Are you able to talk about the trial you have coming up on psilocybin?
I would prefer not to, I think,
Okay,
just because of the recruitment.
sure. Any other projects coming up that you're really excited about?
Well, I mean, I guess one of the exciting things as a researcher, but potentially quite boring for other people, projects that we're working on is essentially to do another Delphi consensus process, but really, really asking specifically about like what are the most important things that you would want to measure if you're doing clinical or research work with psychedelics, so that you can see if they're safe, see if they're effective, and start really generating data at scale that is going to be helpful for regulators, going to be helpful for clinicians, patients, insurance, decision makers, etc. And, you know, it, it's not sexy work. And creating the respect guidelines, although it's a really fun output, was really not sexy work. It was, in many ways quite monotonous. This is not going to be, like bang, psychedelic, really powerful experience sexy, but it's going to be fun. I think in a sense of like really asking some experts from around the world again to make hard decisions about like, if you have 20 minutes, you're going to administer questionnaires. Where do you put your time? And I'm excited about it because I think this is something that every researcher and most clinicians have grappled with. Like, oh my God, look at the psychedelic literature. Should I be spending my time on mystical experience or awe or depression or anxiety or quality of life, whatever? And, there just hasn't been a good process for us all to come together, do this difficult decision making together and land on some sort of consensus about like, if you're going to do this work and you care about measuring stuff, what should that stuff be?
Mm. Sounds pretty sexy to me, but I'm a bit of a geek here. We're coming up on time here, Kyle, Andrew. Any final reflections before we let Kyle go back to his important work?
No, I just want to reflect back the importance of that. What we call the slow and steady work that you've been doing,
Yeah.
Kyle. And we met. I think it's been a while now, maybe not a decade, but it's getting close to there. And watching you sort of slowly navigate this work in the public sector here in Montreal and Quebec. Yeah, it's inspiring the stuff you guys are doing at the lab. I mean, slow and steady and boring some of it, but and we're gonna try and have Michael on the podcast as well. And definitely some stuff that maybe sexy isn't the word, but wild and weird. Definitely in that realm. So yeah, just appreciate it. Keep going.
Michael
Likewise, I
is
mean,
loose to your tight, no?
That's right.
I I don't know how to answer that one. But I mean, indeed, Michael and I, we have a nice synergy because, I do have this, I've been trained in medicine and psychiatry, like to often keep it kind of tight, and I think that's been necessary. As you say, Andrew, I mean, in a field that has seen so much rapid change, it has proven to have been
Yes.
fruitful to just like be methodical, take it slow, and not overpromise, not take money from corporate sectors, all that stuff. Like it's just been good to keep it at scale. But yeah, Michael, on the other hand, is not bound by some of the same constraints that I am, for better or worse. And I think it makes for a really fun lab that we share together because we can kind of hopefully capture some of this massive spectrum for all these, the weird and the wonderful and the boring and the important with psychedelics.
Thanks, Kyle.
Thank
Thank
you
you so
both. It's
much,
been a
Kyle.
real
Yeah.
pleasure. Yeah, thank you, Joe. Thank you, Andrew. Always a real pleasure.